I'm going to talk about the global surgical burden of disease, focusing on Uganda, and with the theme of recognizing surgery as an essential component of public health and universal health coverage. So this is what we are going to cover. We shall look at some common stories from our context in Uganda. We shall define what surgical burden is. We shall look at the global and LMIC perspective. We shall also look at Delhi's, then Uganda through the global surgery realm, and then what can be done, and then a few take-home messages. So by the end of this session, you will be able to describe the global burden, to look at a fair picture of the global burden of surgical disease with the emphasis of LMICs and Uganda. You'll be able to describe what you call DALIs as a measure of death and disability from surgically treatable diseases, and recognize conditions that are recognize surgery, obstetrics, trauma, and anesthesia as essential components of public health and universal health coverage, and then identify the key system gaps that sustain in Uganda's surgical health burden. So these are common stories. I know most of you are pre-interns and some are students, but in your rotations, you've seen, for example, a mother, maybe in northern Uganda, Leptong in prolonged obstructed labor. She needs an emergency C-section, but she chooses to go to a traditional midwife or maybe somewhere that's not a hospital because the nearest hospital is 3 hours away. Or a young man who is on a border driving towards Kamuli, then he gets an accident. He has severe bleeding, but you don't have any car that can take him to Kamuli Hospital. Or you have a farmer in Kumi who has had this swelling, a growing swelling for over 30 years. And then overnight he develops severe pain. But of course, without surgery in hours, this bowel can die from bowel necrosis and it can become septic and die. So when you look at these are common stories and scenarios. So when you look at these, is this a surgical problem? Do you think this could be a transport problem? Could it be a financing problem or health system problem? So, and the common denominator is that most of the things are interlinked. Some of the problems I've highlighted here is that the problem most of the time it is because of all of this. And this is a story that is repeated thousands of times in our hospitals in Uganda. So why is the surgery? Why surgery belongs to public health is one, it prevents death. For example, if you look at C-sections, a mother who is obstructed for long time, you can get a ruptured uterus. When you look at trauma operations that need, for example, emergency stabilization of the fracture or maybe controlling hemostasis and things like that. So surgery prevents death. It prevents disability from, for example, if you don't treat a fracture, someone can get a malunion. Look at things like cleft palates. If a child has a cleft palate and you don't address it, this is a child that is going to have recurrent infections of the upper airway, or maybe is not going to be able to speak well, or maybe is not going to interact with the peers at school well. So the disability that is created from conditions that can be created, conditions that are treated with surgery goes beyond and it continues through school, through social life, and so on. So surgery is able to restore function and enables full participation in society. So surgery also prevents poverty. You look at it from either angle, is that sometimes surgery is very expensive and you need to pay a lot. But again, without surgery, you're not living at maximum health and you may not be able to fend and look for money for your family. So, and I know in the first session, John, that you talked about the evolution of global surgery. A bunch of people in 2015 who spearheaded most of this work in global surgery. I think one of the landmarks was, I think, declaring that surgery is part of universal health coverage, and then looking at some of the indicators, surgical indicators, being tracked across all the countries. So there's a document called the Disease Control Priorities that I think looked at some of the diseases or conditions that we can do at district hospitals to that are cost effective and reduce the entire health burden in our communities. So you cannot have universal health coverage without affordable surgical care. So what do we define as surgical burden of disease? So the surgical burden of disease is the total death, disability, economic loss, and the health system pressure caused by condition requiring surgical, obstetric, trauma, and anesthesia care, and the gap between the need and provision. So surgical burden is not just about operating patients in the theater, but it's about many other things that are behind the patient coming to you in the OR. So the disability, the economic loss from the patient not being productive, the pressures that patients who sometimes need surgery, they need a lot of items in the hospital. Maybe it is lab, maybe it is rehabilitation, and so on. So when you look at the surgical burden of disease, don't look at it from I need to fix this surgical condition and there and then. So there are many other tenets behind surgery. So there are, of course, surgical disease is very broad, but most of the time when you're looking at it in the terms of public health, um, most of the global surgery community talk about mainly these ones. When you look at the Lancet Commission of Global Surgery, it talks about 95% of, I think, diseases are of these diseases, I think, are the ones that when you address this, I think when you create a health system that can address most of these issues, when that health system is strengthened, you can be able to actually address other surgical needs or even non-surgical conditions. So this spectrum of surgical disease is broad. Trauma and injury is very common in Uganda, especially from the young population, from road traffic accidents, trauma also from burns, and obstetric surgery, commonly is the C-section from obstructed labor, emergency surgical conditions like appendicitis, perforated ulcers, IO, peritonitis, and also be congenital anomalies, especially in the pediatrics, for example, the anorectal malformation, hydrocephalus, and neonatal emergencies. Then also from non-communicable diseases and cancers are now quite common, especially vascular diseases associated with diabetes and so on. So I know the first lecture you talked about the Lancet Commission, talking about the 5 billion people lacking access to surgery. Then you have about 143 million additional surgeries needed every year to reverse this burden. And about 33 million people face catastrophic costs from surgery each year. So the main point, I think, in this Lancet Commission is that there is a very big burden, and I think most of the burden is in lower LMICs, the lower middle income countries. So why is the burden bigger in countries like Uganda, which is an LMIC? I know recently there's been conversation that I don't know whether Uganda is a middle income or low income or LMIC. I don't know. That is a bit more political, but not the point of today's lecture. But in Uganda, surgically treatable conditions are never simply treated. Patients die from hernias, appendicitis, injuries that will be routine operations elsewhere. So I had an opportunity to rotate in other settings, high income settings, and one of the things that I saw is that the system is a bit different. That when someone has, for example, like a hernia, you are connected to like your primary care provider. There is a doctor who is a primary care provider. Everyone has a doctor. And then in case there is any surgical need, the primary care provider contacts the surgeon such that it can be treated. So in other words, you don't need to wait for the hernia to become strangulated and then you come to Gulu hospital at 2 a.m. crying in pain. So you reduce the number of emergencies. Actually, most of the emergencies that I saw is mainly trauma, but hernias and so on, most of those are done actually electively. So there are many reasons behind this unmet need. Of course, could be many. I'll talk about some of these, I think, in the next slide. But I think one of them is also delayed access. Maybe the patient doesn't even know what this condition is, or maybe they don't have transport. The roads are very poor, no ambulance, the referral chains are not good. And then when they get to hospital, they don't find any doctor or maybe a nurse, or the facilities lack of even oxygen or even blood. There's no anesthesia, or sometimes it's unaffordable. So, for example, if it is maybe a C-section and the patient needs maybe 20,000 for some small money, I know in some regional referral hospitals, some patients actually cannot afford even 10,000. So what they do, they choose other options, or they decide to just stay with the surgical condition forever and ever. Yeah, because I know ideally surgery is free of charge. We don't have universal health insurance in Uganda, and everything is supposed to be free of charge. But of course, you know, well, the sutures, the sundries, and everything, most of the times you need to contribute some small money. And sometimes some of our patients are so broke that they can't afford that. So they choose to just stay back home because surgery is unaffordable. Or even here in the cities and urban areas, yeah, surgery is very expensive because for you to afford a surgeon, you need to cough some good amount. So I think some of these, I think difference is that I think one of the things that can be used here is having maybe health insurance where everyone can be able to get care. I think if everyone can contribute to the pool of money, and then seeing that anyone, you can go to any regional referral hospital and get a specialist, I think that will help a lot. So then also the other thing, when you look about the burden of disease, there is another term that public health specialists use, which you call the DALYs, which are what you call the disability adjusted life years. So usually one DALY is 1 year lost, one lost year of healthy life. And to calculate the disability adjusted life years, you use a calculation of, you calculate it with years of life lost plus years lived with disability. So I'll explain this further with an example, but these are very, why this, relating this to surgery is because one, when you look at, for example, a young patient who dies from sepsis, from a perforated appendix, in Uganda, the life expectancy, is it around 65? I think 65 years. So if a person dies maybe at 20 years, so in that case, you've lost a lot of life. You would have lived up to 60, but you've died because of sepsis from an appendix. So surgical conditions can contribute to years of life lost. So, and as such, you will see that most of the people are dying very early, and you don't have very old people, maybe to 80s, 90s, and so on. Then also, a woman living, for example, with obstetric fistula, after obstructed labor, accumulates, of course, disability. Disability because most of these women with fistula, maybe they are shunned, there's a lot of stigma, maybe sometimes even the fistula, if it is a colovaginal fistula, they are leaking a lot of stool, the smell is not good, they're in social isolation, they cannot go to fend for their families, they are not earning. So that's all disability. So you cannot tell me a person with a fistula is living a wholesome life compared to a person who doesn't have a fistula. So you're living, but it's like as if you're not living. So that is what we call years of life with disability. So in the public health spectrum, usually when you look at a disease, for example, you look at it in the lens of the years of life lost and years of life with disability. Yeah, and I think most of the time when public health economists are looking at investing, for example, in primary prevention, trying to see where to invest money and getting a benefit for the money, because you have to invest somewhere where it is cost effective, you're getting maximum benefit from little amount of money that you're putting in. So I think some of the things that they look at is this. How many years of life are you going to save from investing, for example, in an operating room to work on mothers such that they do not get obstructed? How many disability years are you going to reverse by, for example, having maybe an occupational therapist who is going to help rehabilitate and do maybe some physio exercises from someone who got an accident and cannot ambulate well? So that's an entire discussion, but what I wanted to show in this slide is that surgery is very uniquely powerful because it addresses both components of the DALI formula, because some of the diseases that require surgery, someone is going to die at a very early age. And then some of the diseases that cause disability, of course, are also can be reversed with surgery. So just also to highlight this with an example, for example, if you have John, a 30-year-old farmer, he has a fracture in a motorcycle accident. He reaches hospital 3 days late. The leg cannot be saved. So as a surgeon, you decide that let me amputate this guy. So John lives up to 60 years, assuming that the life expectancy in Uganda is 65 years. So how many years of life are lost in John's scenario? So if the life expectancy is 65 and he died at 60, so meaning the years of life lost is 5 years. How about the years of life lived with disability? So after you chop off his leg, I don't think the 30 more years he lived after that amputation are the same as he would have lived with his full leg. So there is something we call a TTO, or what you call a time to trade-off. You ask the patient, how many years would you trade for the years you've lived with disability? So in this case, John lived, for example, for 30 years, and you ask her, for the time you spent with a disability, how many perfect health years could you trade for those 30 years? So he can say, for example, yeah, I've lived with this disability for 30 years, but if I had an opportunity, God to help me, I would have loved to at least have 15 years fully with my 2 legs than having 1 leg in 30 years. So that is what we call a time to trade off. So in this case, you can use this to calculate what we call the health utility value. And then there's another term we call the disability weights, and different diseases. Public health experts have used different calculations to get the disability weights. But just to simplify this one, is that from this guy, because he lived 30 years, he would prefer 15 full years of full life compared to 30 the disability. So in that case, the health utility value is 15 divided by 30, which is 0.5. So for the 30 years he has lived, it's like as if he has lived half of his life. So the years of life lived disability in this case is 15. So in this case, the total DALIs become the years of life lost, which is 5 years, plus the years of life with disability, which is 15. So in the case, so this is adjusted life years is 20 years. So therefore, John lost 20 full years of healthy life by dying at 60 years. 5 from early death because he died prematurely, and 15 from the disability. So that is how DALIs are looked upon. But again, what you can see in this picture is that surgery, when most of the people, when they are talking about public health interventions, malaria, they like talking about, okay, if we vaccinate against rotavirus, how many years of life do we save? For example, if a baby dies from acute watery diarrhea with severe dehydration, if a baby dies at 2 years and the life expectancy is 65, so that is 63. So that is why sometimes these public health experts put money where you have maximum benefits. But again, what we can see here is a surgery falls also along the spectrum, is that you lose life and it can also be used to reverse disability. So as I was talking about, the surgical burden is broad, but most of the time the global surgery spheres, most common surgical burdens in Uganda, I think it's road traffic accidents are the leading cause. Again, trauma, there's also burns, but injury is very, very important. Then regarding maternal and neonatal surgery, C-sections, access to early C-sections when a patient needs them, obstetric emergencies like PPH. And of course, Uganda's maternal mortality ratio is falling, but still around 189 per 100,000. So it's still up there. We need to do some more work, but I think those are some of the things that I think you need: a good surgical system, a good OR if a patient needs C-section, or maybe you need to go back to do a hysterectomy, so you need surgery in that case. Emergency general surgery conditions like hernias, appendix, IOs, a pediatric surgical condition like congenital anomalies, hydrocephalus, and rectal malformations also have a high unmet need. And also there is a growing burden of cancers. Breast, cervical, prostate cancer, colorectal are increasingly being noticed in Uganda, and especially also in the younger populations. So the biggest challenge we have in Uganda is that we do not systematically measure the surgical burden of disease. The data gaps hamper planning and advocacy. And this is a very important point because, of course, there is some work. Some people are doing some work in trauma and so on. But again, if you need the values of most of the things, most of the time they are old values and you don't have updated registries and things like that. So when you look at to reduce, when you want to, if we are to reduce the surgical burden, it's not just about going to the OR and working on patients, operating as many patients. So we need to look beyond the OR, the theater. You need to go outside the theater and look at the entire spectrum. So you must strengthen the entire pathway from the community. Why don't patients come to the hospital when they have a hernia? So transport, if a patient gets, for example, a fracture, what happens? Is there an ambulance? Is the road working well? So surgeons need to work with other people, maybe public health officials, or maybe city planners, district planners. Of course, if the road is very poor, there is no way you're going to reach hospital. Or for a mother who, for example, would need a C-section within 2 hours. If the road is very, very poor, it means that you will take 6 hours and maybe that mother won't make it. So there are many other things outside the OR. So, and you also look at the OR itself in the facility. Are there the surgical people that are going to do the operations? Are there the nurses? Are there the anesthetists? Is there blood, oxygen, and things like that? Also, surgery doesn't stop there. You also have post-op. You may operate on your patient and they get a cardiac arrest. Can you monitor your patients in the post-anesthesia care unit? Recovery itself, patients sometimes are so sick and they need maybe occupational therapy, physiotherapies, integration into the community and things like that. So it's the entire spectrum. So if we need to touch anything to do with the surgical burden of disease, you need to look at all these time points and try to see where you can fit in and try to address the different gaps. So of course it takes a big effort, and it needs teamwork, working with many people and to solve most of the things. Yeah, so where are the gaps in Uganda? If you're looking at the Lancet Commission, the health information, again, do we know the true burden? How many accidents occurred in Uganda? How many fractures did we have in Uganda last year, for example? Do we track surgical outcomes? What happens to the patients who come with fractures in our hospitals? How many vascular injuries do we have? Surface delivery, how many patients can reach timely within the hospitals? What proportion of patients reach within 2 hours last year in Ugandan hospitals? How many surgeons do we have in Uganda? How many anesthetists or anesthesiologists, obstetricians, nurses? How many ORs do we have in the country? How many blood banks do we have in the country? How close is the blood bank to the hospital? How long does it take to get blood from the blood bank to the hospital? How much do patients pay to get surgery? So how much what is the cost of surgery for the hospitals? And do we have any policies, maybe any plans that are happening? How are we organizing surgery, and what are we doing to create policies and plans about surgery? So there are many gaps. It's overwhelming, but of course, it takes a step at a time. And the evidence in Uganda, of course, maybe in the first lecture, it also talked about this surgical volume. I think most of the papers that I saw I think are very old. And there's a paper that quoted about 144 per 100,000 people per year surgical volume. The specialist density, of course, is less than 1 per 100,000. Anesthesia density also barely. So Uganda has not met the Lancet targets. And I think the last time I checked on the World Health Organization, there is a forum where they, I think, track some of these surgical indicators that were chosen. From that meeting in 2015, I think I saw Uganda tracked, I think, twice. I think the last data I saw was in 2016. So meaning we are not tracking some of these things. There was a very good push, of course, 2015, 2017. It was a good year, a lot of impetus for global surgery and movement, but things seem a bit slow. But of course, we need to ask ourselves, Uganda, what can we do? So there's the limited routine measurement of the surgical need, outcome, mortality, data about financial implications of surgery, and registries, of course, are very common, and they are non-existent in most facilities. But of course, I think one of the things that is coming up is the IFIA system. I think once most of the hospitals transition to that system where everything is electronically collected, maybe we shall have some good data about that. Okay. So what are some of the key conclusions? Of course, we need to measure. We need to do the research, measure. We need to have registries, audits, have an HMIS. We need to strengthen the capacity at district and regional hospitals, invest in infrastructure, theaters, oxygen, equipment, train and retrain more surgical providers, anesthetists, nurses, improving systems, and protect patients from catastrophic costs. So that is what we can do to address the surgical burden of disease. Yeah, this is a bit overwhelming. So you may ask yourself, of course, I'm a student. What can I do? This is a bit maybe Minister of Health and so on. Hiseru, can you please don't write in the slides? I think you're scribbling in the slides. Thank you. So I was saying that this is a bit overwhelming. So you may ask yourself, where can I start? The solutions are there. There are a lot of people have suggested many solutions, but I think one of the most important things is for you to start somewhere, team up with people who are like-minded. And I'm happy for this Global North Star program that you have a bunch of young people. You have also mentors in Eric and who are really interested in mentoring you and starting slowly and slowly. So over time, you build a community of people. You may not do everything at once, but slowly and steadily you can do some work that adds on, and in future we can see some of these successes. So your role is this: you don't need to be a consultant surgeon or to do something, but you can start as a pre-intern. As a pre-intern, you're going to go to these facilities. So start by asking yourself, okay, what can I do? Can I do maybe a quality improvement project? Can I document some of the challenges here? By documenting some of these challenges, you can also come maybe like the ASOL conference or any other regional conferences, share, get to listen to people, see how they think about some of these things, and team up, get projects and things like that. So there's a lot of work needed measuring the burden. I think one of the work, I think for Rwanda, they made their NSOP plan, but I think one of the things they leveraged on a lot is using students, residents. Rwanda is a smaller country. I think that they are more aggressive than us. So, but of course, getting some of the data on surgical case volume. So imagine, for example, you have interns in maybe around 80 regional referral hospitals. Imagine that you have maybe a global surgery champion in most of these hospitals. So over the full year, you can actually find out the number of surgical volume, for example, by working with maybe John, you can spearhead this and maybe get in touch with your other interns entire country and get a paper maybe you can submit to us all maybe next year, something like that. So it's all about starting sometimes. So it's not just about wishful thinking, but you need to start somewhere. So measure the burden where you are, build registries, run audits, write case reports are easy. Be interested in a surgical case report, write about it, read about it, see how other people managing this case, what would I have done differently? So of course, as a clinician, of course, where you are, train others. So try to do the best you can for your patients, audit your outcome, have periodic meetings, QIs, and so on. Advocate, push for surgery. You can use social media. Of course, some of this you need the Minister of Health and other people who really influence policy, but you can start slowly, attend meetings, work with people, and so on. Then also innovate, create ingenious solutions. Where there is a problem, think of a solution. There are many problems that are in our system. Maybe it is in your hospital, you have a lot of wounds, and maybe there is a different way you can use maybe to dress wounds or something like that. So knowledge is out there. There are a lot of resources, but the only difference that you're going to make is for you to sit down at some point and maybe 10 p.m. after your round, or maybe when you're at home, and think, research about something on your computer, and then start from there. Start on something small, get advice from people, and then build on that slowly by slowly. That is how you can fight and we can make a change on this. So the key takeaways, as I summarize, that surgical disease is a very major, often hidden contributor of death and disability globally, especially in Uganda. Dailies show that surgery is both life-saving and disability-preventing, making it uniquely very powerful as a public health intervention. And reducing Uganda's surgical burden requires a systems approach. We need the data, we need to improve access, workforce, infrastructure, financing, and governance. Yeah, so thank you so much for listening to me. So maybe at this junction, I would maybe entertain a few questions before I get excused. Thank you.